Good morning, everybody. Welcome to Global Neurosciences Institute Grand Round Series. And now it is my pleasure to introduce today's speaker, Dr. Evcon Kolpan. Dr. Kolpan obtained his medical degree at Çukurova University School of Medicine in Turkey. After finishing neurosurgery residency program at Ankara University School of Medicine, he did postdoctoral research at Illinois Institute of Technology on brain electrophysiology and neuromodulation. His second residency was at the University of Minnesota Department of Neurosurgery. Then he completed stereotactic and functional neurosurgery fellowship program at University of Illinois at Chicago. Dr. Colpan has special interest in neurosurgical pain treatment, deep brain stimulation, neuromodulation, and epilepsy surgery. He had faculty appointments at the University of Pittsburgh Medical Center, University of South Florida, Marsanis College of Medicine, and Philadelphia College of Osteopathic Medicine. He was the director of stereotactic and functional neurosurgery at Lehigh Valley Health Network and joined Global Neurosciences Institute at 2021. And Dr. Colpan will be speaking today about neurosurgical pain treatment options. Dr. Colpan.
Thank you very much for this introduction. So my name is Evcon Kolpan. I'm a neurosurgeon. I work at the Global Neuroscience Institute. As Peter introduced me, I have a special interest for the chronic pain treatment and neurosurgical pain treatments. So I would like to introduce I would like to present neurosurgical pain treatments today because chronic pain is getting everyday big issue in our life and society and also in the medical practice. Because if you take a look overall medical trends, so right now we have better oncology care and cancer patients are surviving longer. And also we have different chemotherapy and different radiation modality for cancer treatment. Of course, chemotherapy and radiation therapy not only goes through the cancer tissue, goes through the affected body and nerve, which cause chronic pain. It is not uncommon in cancer patient population having chronic pain. About 30% cancer patient most get sort of chronic pain and 10% get medically intractable chronic pain. So, as well as other area, stroke area, we did quite establishment in stroke care and stroke survivability. After stroke, so 1 to 8% patient get chronic pain, particularly central pain that we call. This patient population very resistant to medical management and medication for treatment, as well as other areas, spine care. So we had quite progress in spine care, and today increasing number of fusion, laminectomy, and other spinal procedures. Also increasing the chronic pain because as those care provide a quite good outcome, some patient population who are having this care developing chronic pain because it's of nature of the nerve decompression going through the surrounding nerves creates scarring that create post-laminectomy, chronic pain and failback syndrome and arachnoiditis. These patient populations are also very resistant to medical care and non-invasive pain treatments. That is the reason I would like to talk about neurosurgical pain treatment and surgical pain treatments, because neurosurgical pain treatments and surgical pain treatments usually in our practice underutilized, and a lot of patients out there not aware of it, and as well as physician get some solution for suffering chronic pain patients. So, if you take a look, burden of chronic pain, so pain is the most common reason people see a physician. Affect at least 20 3%, 23.5 million adults in the United States, and cost related with that $635 billion to the society. Prevalence is really high, and as well as every day increasing number of chronic pain patients that increase the number of opioid use and opioid dependency and secondary problem associated with that. If you take a look the description of the pain, pain is an unpleasant sensory and emotional experience associated with actual and potential tissue damage. Pain is most often a symptom or a warning of an underlying issue which threaten our well-being and survival. However, sometimes pain stops playing a protective role, then becomes our enemy and may necessarily treatment. If we take a look available treatment options and understand to pain, there is two concepts to understand the pain as an origin of pain. One is nociceptive pain. That means pain caused by tissue injury in joint, bone, muscle, various internal organs, and nervous system healthy, nervous system picking that in right direction, right way, and transmitting through the brain, and we sense the pain. That is nociceptive pain that happen through the tissue damage or potential tissue damage. Other concept is neuropathic pain to understand. Neuropathic pain, pain initiated or caused by a primary lesion or dysfunction in the nervous system. Basically, either peripheral tissue damage happening or not happening, sometimes itself damage or misinterpretation, and or misconnection in the central nervous system and nerve that create pain. This is neuropathic pain. Algorithmic approach necessarily understand the pain, because most important thing to understand chronic pain and etiology, and go through the available right medication, right therapy, as necessarily right surgical intervention. Underlying pathology is very important, as we described. The nervous system is working well, properly, or just both side tissue damage happening, nervous system is not working well, combination. Anatomic distribution of the pain, pain characteristic, pain, patient's age and medical condition, comorbid situation, associated medical issue, and history of previously surgical treatments, result of psychological evaluation in some cases also important, because pain is not one perspective. There is a multiple perspective of pain, because it is a sense and subjective feeling. So emotion, having depressive, anxiety, culture, and all factors affect the interpretation of pain and pain sense. Most often we do ask the pain duration, acute or chronic. Chronic, mostly that we could describe pain persistently presenting and happening more than 6 months. Of course, severity of the pain, we use a visual analog scale, basically 0 to 10 scale, to understand how much pain and how severe it is, and as well as location of the pain to understand dermatomal distribution, associated nerve, associated pathology, type of the pain, aching pain, burning pain, pinning pain, associated numbness, dysesthesia. These are all give us clue to understand source of the pain and reason of the pain to get the right treatment, to pick the right treatment option. Wrong diagnosis is frequent cause of refractoriness to treatment, of course. What are available for pain treatments? So medication, as usually, and physical therapy, behavior therapy, interventional therapies, and surgical therapies. As I wrote down, so first line, we try medication. If pain subside, respond to medication, either we stay on the medication. At physical therapy, behavior therapy, these are non-invasive, of course, as in first-line therapy, then interventional and surgical therapy, like a third tier. Who may be candidate for surgical treatment? So answer is medically intractable chronic pain. What is medically intractable chronic pain? Medically intractable chronic pain, the pain persisting more than 6 months. And even patient try, get available conservative treatment options and combination. Fail to get good pain control and respond to non-conservative treatment option, and then candidate for some surgical intervention if life of quality is still not good and not having good pain control. So if we take a look at possible surgical therapies for managing chronic cancer, chronic pain, so there is a few different modalities. Historically, perform a procedure more destructive. Destruction or lesioning or ablation are same term that target the interruption of peripheral, central, or in the brain pain pathway. Then simple disconnection, logically manner to solve the problem, and medically intractable pain, either benign or malignant origin. However, with this approach, necessarily first invasive, the second damaging the pain pathway, which working normally, as well as damaging body coded for recovery. So body does not understand it is medical purpose. We want to disconnect the pain pathway. Body coded for recovery, then the damaged pathway of the pain pathways get start recovered, and the duration of the treatment sometimes may not be satisfactory enough long. Other modality that we learn with the advance of electronic and technology and medicine as well. We learn without destructing the neural tissue, we can alter the neural activity through the electricity or chemical locally delivered through the necessary area that we call the neuromodulation, basically neuromodulation through the electricity and as well as pharmacology agents. Another category for the available surgical treatments, we count in others as a category in textbooks and pain surgery practice. These are decompressive procedures. So we do a lot other procedure available, like a foraminotomy, entrapment syndrome, decompression, like a carpal tunnel, piriformis syndrome, decompressing the piriformis muscle, These are all pain-related procedure, but not only pain. Sometimes these syndromes, pain syndromes, associated with the motor or other reflex issue, then we do not count these surgical treatment option as a pure surgical pain procedure. Other entity for the trigeminal chronic pain, trigeminal neuralgia, that we do microvascular decompression at the root entry zone, that we count. This is neurosurgical and surgical pain treatment. So if we go through, as illustrated here, if we go through the brain through the peripheral organ, if you disconnect any pathway through the brain, for instance, cingulum, it is most associated with the pain, sensation, and emotion and memory, that we can treat the different perspective of the pain, and as well as other areas like mesencephalectomy at the spinal level, dorsal entry zone lesioning available, and also cordotomy for the cancer patient, nerve root sympathectomy, and neuroma resection. These are available for as an destructive procedure. Neuromodulation, again, we can get through the brain, through the down to the end organ nerve root. So motor cortex stimulator, spinal cord stimulator, as well as peripheral nerve stimulator, and intrathecal therapies are available, intrathecal morphine pump, and other applications. If we take a look ablative procedures, we can use different surgical approach. One would be a direct sectioning of the nerve and pain pathway. Other would be radiofrequency source to damage the disconnected neural pathway, and thermal probe, laser probe, and radiosurgery, stereotactic radiosurgery also available. If we go through the top to down, some neurosurgical procedures, most in the brain that we do as a neurosurgeon, some these pain procedure can be done with the other subspecialty like anesthesiologist or orthopedic surgeon. I'm talking overall neurosurgical part, as well as that we do as a neurosurgeon in our practice. Cingulum is a target, anterior cingulum is a target for pain control, and it most function to understand memory and feeling and emotional part of the pain. So cingulotomy may be a safe treatment option with minimal cognitive change who have medically refractory cancer pain with diffuse pain syndrome, head and neck malignancy, and significant emotional distress. So anterior cingulum area, when we do create lesion there, either using stereotactic radiosurgery or inserting a laser probe or radiofrequency probe, that we can create as seen here in the MRI scan lesion, that disconnect this area related with the puppet circuit and limbic system that helps patients pain relief who has more emotional component of the pain. Interestingly, when we do this procedure, patient clearly say, I'm still feeling this pain, but it is not hurting me anymore. It is a very interesting, usual procedure in selective patients. Medial thalamotomy is a central lesioning procedure, other central lesioning procedures in the pain pathway for chronic pain treatment and target. Stereotactic radiosurgery for treatment chronic pain, intraocular pain, and mediodorsal and basal thalamic, either radiofrequency or radiosurgical lesioning can be used for unilateral somatic nociceptive and neuropathic body cancer pain, may be more effective for pain involving the face and upper body. Potential complications such as transient diplopy, confusion, delirium have been reported. Medial thalamotomy is not a common procedure in our practice now, and still available for some selected patients because I will mention in the upcoming slides. Right now we have different neuromodulation procedures, less invasive and has also more success rate. Trend in the neurosurgical pain practice more go through the neuromodulation instead of central lesioning procedures. Hypophysectomy, other historical procedure with good success rate, but unfortunately itself either through surgically or radiosurgically. Radiosurgically, it is less invasive, non-invasive, but still when we do hypophysectomy, quite complication associated with that panhypopituitarism and electrolyte fluid problem, then this procedure getting lost of in our practice because a lot of associated complication with that. Almost we are not performing this procedure in pain practice. Mesencephalectomy, mesencephalum, other location for disrupting pain pathway, particularly spinothalamic tract, and as well as trigeminal thalamic pathway. So this procedure again useful for selected patient. Longevity is about 6 months or less, then favorable for such a cancer patient if indicated. But for the non-cancer patient, it is sort of not applicable with the duration of the pain relief. When we come to spinal cord level, so the dorsal root, dorsal rootlets and dorsal root entry zone modulate the pain sensation, and this area is another target for lesioning. Selective dorsal root rhizotomy for selective nerve root pain is applicable in our practice. It works well, particularly brachial plexus avulsions, and as well as brachial plexus injury, then as well as lung upper lobe cancer invading brachial plexus that we call the Pancoast tumor. Other lesioning procedure and target either cranial nerve rhizotomies and or peripheral nerve rhizotomies. So Cranial rhizotomies for trigeminal neuralgia, well known, very well effective procedure for selected patients again who have who's elderly, has trigeminal persistent pain. This procedure, minimal invasive, just needle procedure, percutaneous, applicable with good outcome. But again, destructive procedure creates some dysesthesia in the face area where the pain located, as well as nucleus caudalis DRES lesioning, also rhizotomy procedure. This is applicable for some facial cancer pain, and as well as that we call anesthesia dolorosa, secondary to trigeminal nerve damage, numbness and pain syndrome. This central procedure also available. Peripheral nerve rhizotomy for occipital neuralgia and cervical facet joint, lumbar facet joint, widely performed in spine practice as well as for occipital neuralgia. Outcome manner, it is a reasonable procedure, but again, all nerve body coded recovery when we create oblate facet joint nerve and do rhizotomy procedure. This nerve get alive in some point, rejuvenate, then start having pain, creating pain or other pain. Most like a facet joint rhizotomy procedure, either lumbar, cervical, provide 3 months to a year some pain relief. Then either pain comes same way or different pain comes, because when we destruct the nerve, sometimes pain creates, nerve creates a pain as a neuropathic pain. It is not unusual that we hear some low back pain patient comes after rhizotomy complaining, I was having different pain, then I did the rhizotomy, it got better, than having right now different worse pain or different aching pain that would be secondary recovery and neuropathic pain associated with the destructive procedure itself. Occipital rhizotomy, occipital nerve rhizotomy also had been performed with reasonable outcome. Again, about their some 6 months to year pain relief in most cases. As I mentioned, trigeminal rhizotomy, it is a percutaneous procedure for the selected patient, has good success rate, higher initial success, about 99%, but a significant rate of dysesthesia, about 23%. Then corneal reflex sometimes affect with this procedure. Keratitis has been reported, and motor weakness also as a complication associated with that. Cordotomy procedure target to spinothalamic tract at the C1, C2 level in the cervical area, in the spinal cord. It is a well-known procedure with relatively less side effect and complication rate. It can be performed open and or CT guided percutaneous approach. After Dr. Campolat described CT guided percutaneous cordotomy, it get more popular in neurosurgical practice, pain practice. It provides unilateral somatic limb and trunk pain relief, either related malignancy, in most in malignancy, malignant reason. So of course it has side effect because associated close proximity of motor pathway as well as anterior horn nuclei and anterior horn. So there is weakness associated with that. Then again, when we create lesioning in the central nervous system or peripheral nervous system, sometimes recovery happen. When the recovery happen, nerve connection may get abnormal, then itself create dysesthesia and neuropathic pain. Myelotomy, another procedure that we do in neurosurgical practice. This procedure target through the transfer connecting pain pathway at the middle of the spinal cord and anterior commissure. So basically, this procedure is effective for pelvic pain due to malignancy, and as well as abdominal pain and malignancy related. So medial myelotomy, 30% patient pains comes back in 6 months. So again, longevity of the and duration of the pain relief very important with the procedure itself and the technique and patient itself particular circumstance. Another location for lesioning, dorsal ganglionectomy, dorsal ganglion. Dorsal ganglion is a ganglion take the sensation and sense through the nerve root. So early studies for the dorsal ganglionectomy for the failed back syndrome was hopeful, but the long 5 years follow-up demonstrated most patient pain is getting return and getting a different way. Thoracic region, thoracic area also applicable. Thoracic area pains are also treatable with the ganglionectomy procedure. Dorsal ganglionectomy had been performed for the occipital neuralgia. Initially, we had a good outcome, but careful survival analysis demonstrated most patient pain is coming back 6 months to 3 years, but still applicable. And who has not wanted to get implant or such a chronic therapy that I will mention about neuromodulation part of the presentation. Other approach could be for Zhang lesioning procedure, neurotomy or Neuroma Excision. Basically, where the pain coming, such an occipital nerve for the occipital neuralgia, genitofemoral chronic pain from the genitofemoral nerve, ilioinguinal nerve, femoral nerve, and lesser sciatic and pudendal nerve. Could be targeted for this procedure. Basically, they're open that we go find the nerve, disconnect the nerve, and or put image guided through the ultrasound, CT guided, either laser probe, radio frequency probe, or other energy source to destruct the nerve. These procedures, again, applicable with sort of short longevity of pain relief. Neuroma, such a Morton neuroma, still in our practice, most surgeons remove the neuroma, for instance, such a Morton neuroma, develop associated with the chronic trauma. However, when we remove the neuroma, that we learn when we cut the nerve, so nerve coded recover, then another neuroma happened, then we need sometimes go repeat the procedure, repeat it again. Right now, we have more option like a neuromodulation than the practice trending through the instead of touching nerve and being invasive, choosing a different approach and as well as less invasive, different modality like neuromodulation. Sympathectomy, another target for lesioning for pain relief. It is well-known procedure. It is indicated for most visceral pain, abdominal, pelvic, chest cavity, and as well as ischemic pain, ischemic-related pain. We can do sympathetic temporary testing, sympathetic chain block through the needle procedure. If patient responding who has abdominal, pelvic, chest area pain, then would be candidate for this procedure. This procedure works well who had chest surgery, scarring related pain, abdominal surgery, scarring related pain, as well as chronic pancreatitis or pancreas cancer related chronic pain. When we come to neuromodulation, so as we spoke, neuromodulation is a modulating, altering the neural function and improving the symptoms, pain, and associated with that improving quality of life. So if we go through the neuromodulation procedures available through the top to down, so one is a motor cortex stimulation. Motor cortex has a close relation with the sensory cortex, and there is U fibers connected with each other area. We do not know really how the motor cortex stimulation help for the pain, but it helps, it does. With our experience, selected patients are good candidate for this procedure, particularly like hemifacial face cancer, and central pain syndrome associated with stroke, limb pain, of course, post-stroke pain. 1 to 8% stroke patient get post-stroke chronic pain, central pain, post-herpetic neuralgia also one of the good indication for this procedure. Basically, we do functional MRI, we localize the motor cortex, then go through small craniotomy or burr hole with silicone electrode under the skull, over the brain cover, durometer, localizing motor cortex, then test stimulation, then final implant if patient getting at least 50% pain relief. If we take a look outcome with it, so 60% patient post-herpetic post-stroke patient respond this pain, at least get 50% pain relief. 75% patient with neuropathic trigeminal nerve respond this therapy, and 60% spinal cord injury patient, and 53% phantom pain, phantom limb pain, and 45% patient with brachial plexus injury also respond this therapy. Other approach could be for the central modulation of the pain, deep brain stimulation. Deep brain stimulation targets in the brain for pain treatment, periventricular gray matter and aqueductal gray matter. This area associated with neuroenkephalin and endorphin release. Stimulation of this area helps for the pain relief. Also, sensory thalamus and internal capsula also target for the deep brain stimulation. Deep brain stimulation possible effects on pain: increase endogenous opioid secretion, intracortical GABAergic inhibition, reduction of thalamic hyperactivity, and emotion and affective component of the pain. If we take a look at numbers, so periaqueductal gray matter and as well as plus thalamus and internal capsula stimulations provide pain relief. Either combination, putting more than one electrode could provide pain relief. Most effective multiple has been reported in the literature through the periaqueductal and thalamic and internal capsula multiple electrode stimulation provide 87% pain relief. And as well as we test if this effective by the test stimulation and working on the patient or not, could figure out before going through the implant. Is a good option for selected patient population. Spinal cord stimulator is well known and relatively new approach treating variety of chronic pain syndrome in the spinal cord level. It is FDA approved device and procedure. There is a strong evidence spinal cord stimulator provide pain relief, reduction of pain medication, improvement of depression, return to work, return to daily activity, and as well as increasing quality of life. Spinal cord stimulator can be performed to treat Fehlbeck syndrome, arachnoiditis, reflex sympathetic dystrophy, the old name complex regional pain syndrome, intractable angina, and phantom limb pain, peripheral neuropathies, radiculopathy, peripheral vascular disease due to ischemia and ischemia-related pain. Overall success rate, 70% patient respond, at least get 50% pain relief with this therapy. It can be applicable through the cervical, thoracic, and cover the cervical and torso pain, and as well as low back pain and radicular pain. We have different electrode design, and we have ability to locate this electrode in different location to cover, depend on pain location and pain nature. We have ability to change the polarity of stimulation and as well as the parameters of stimulation to get a better pain control. Another neuromodulation approach is dorsal root ganglion stimulator. So as illustrated here, spinal cord stimulator goes through the dorsal column and dorsal root entry zone. The dorsal root ganglion located in the back, and dorsal root ganglion stimulator goes through the ganglion directly, as seen in the X-ray, small tiny electrode that we place through the small needle through the epidural approach. So particularly dorsal ganglion stimulator can be applicable for Fehlbeck syndrome, intractable low back pain, leg pain, post-surgical groin pain, post-surgical knee pain, abdominal pain, sacral pain. This has superiority when we compare the spinal cord stimulator, because has 95% stimulation specificity in the local area. So for instance, patient had inguinal surgery, then created chronic pain related with the scarring or either nerve damage there later than inguinal surgery. This patient will respond to dorsal ganglion stimulator. Of course, as we all have get arthritis, joint problem, knee hip replacement, secondary problem, chronic pain, this patient population really get good outcome with this stimulator. As well as groin pain, foot pain, body pain, good indication in selected patients. Overall success rate is about 74%, at least 74% patient get at least 50% or more pain relief by this therapy. We do a trial. Then if a patient report more than 50% pain relief, warrant to get the implant. And we teach the patient how to use the implant. These implants are very smart, all neuromodulation implants for the pain. So a patient gets controller, could have a different program for different day hours, different pain to manage the pain and get the life of quality better. Peripheral nerve stimulation, also well-known approach as a neuromodulation, neuromodulatory treatment. Peripheral nerve stimulation can be performed for occipital neuralgia and face pain and upper extremity pain, pain in the torso, pelvic pain, lumbar area pain, or peripheral pain like peroneal, common peroneal nerve pain, cutaneous pain, tibial pain, and other any nerve giving particular pain related with either tissue damage or itself the nerve. It goes through the nerve affected on the side using a percutaneous needle and through the needle electrode, small wire electrode. It works. The hypothesis that had been proposed to effect of peripheral nerve stimulator. Wall and Malzek proposed that C fibers produce in the peripheral nerve pain, and stimulation of large myelinated fibers affect the interneurons and creates and diminish the pain sensation at the spinal cord level by the stimulating the peripheral nerve. So indication for PNS, peripheral nerve stimulator, post-herpetic neuralgia, post-traumatic or post-surgical neuropathic pain, classic migraine, transformed migraine, and occipital pain, occipital discomfort, hemicrania continu, occipital neuralgia, cervicogenic occipital pain, complex regional pain syndrome, cluster headache, chronic daily headache, also one of the indication again for the selected patient population. And trigeminal facial pain respond 50 to 80% at least overall patient satisfaction 70% with this therapy. It can be performed supraorbital, infraorbital, and it can be performed through the occipital nerve or other nerve distribution. So occipital neuralgia is common, a relatively common problem. So peripheral nerve stimulator had been reported in general literature, effective for it 37 to 100%. about their 66% with the mode. Occipital neuralgia, cervicogenic headache, post-traumatic occipital neuralgia, refractory cluster headache, refractory chronic migraine, also treatable with this approach. As illustrated here, electrode could be positioned in different direction to treat different type of headache or occipital pain. Another approach as a neuromodulation treatment is intrathecal therapy. Basically, the hypothesis and the therapy came in our practice with the hypothesis of delivering the medication and modulating the neural function in local area. So when we get oral medication, medication dissolve in our body, and if we try to like one in spinal cord where needs to be effective and provide treatment effect, then we have to give 10 times more medication because it dissolves in the body. If we have ability, as we had, go through the put small catheter through the spinal sac and deliver local medication in the segment of the spine, that will provide better pain control with a small amount of medication that also provide minimizing the oral medication side effects. Who are candidate for this procedure? Who has chronic pain, either not responding opioids, because when we put this small catheter, we can give less amount of medication where it needs to be that could provide pain control, even sometimes patient not responding to oral medication or higher dose medication. So we do trials where we inject medication locally into spinal sac. If patient getting relief and happy with that, through the needle procedure that we place a catheter to the spinal sac and relevant level of the spine and spinal cord to deliver a variety of medication, including morphine, some local anesthetic, clonidine, and others applicable with that device. So indication for impractical therapy, the chronic cancer pain, also one of the good indication, metastasis, neuropathy, post-chemotherapy, neuropathic pain, nerve irritation, injury from radiation. So non-cancer indication, Fehlbeck syndrome, peripheral neuropathy, complex regional pain syndrome, severe osteoarthritis, rheumatoid arthritis, that we call these patients in like a chronic pain syndrome. So also indicated using this device. Basically, implantable pump with a port placed through the side of the abdomen. Tiny catheter goes through the sac and located where the relevant area for the pain and pain treatment. Then it has a rubber access to fill it. Then we mixture either some morphine, local anesthetic, or other medication to provide better pain through the programmable continue infusion through the intrathecal area and spinal sac. It is helpful and very effective for selected patients also. So as I mentioned, other procedure, decompressive microvascular decompression. I will just like a brief mention about it because in the past GNI Grand Round series, Dr. Liebman presented all the detail about decompressive trigeminal pain treatment, and as well as decompressive microvascular decompression procedure. I would like to reference at this opportunity. It is effective and curative procedure. So basically, we go through the find the neurovascular conflict through the root entry zone, and pack with the Teflon cottonoid, remove this artery, and helps chronic trigeminal nerve and trigeminal related pain. It is very successful procedure, but invasive. Again, for the selective young patient who could tolerate the procedure, would be a good pick for trigeminal neuralgia treatment. So when we get overall, like a compare ablative procedure and or lesioning that we call the same destructive procedure, and with the neuromodulation. So basically, ablative procedures has high risk for neurologic complication and destruct the neural structure and neural pathway as hypothesis to treat the pain. And the conflict with that, the body used to and coded for repair and rejuvenate, and some point pain comes back, and in most treatment effects shorter in general. As well as there is some irreversible neurologic problem may occur with this approach, while destructing close proximity neural structure or pathway may affect that it might be irreversible. And benefit of it, it is simple, one procedure, repeatable in most if comes back, no need for implant placement. Select the patient, it is a good option, like a short life expected cancer patient fall in this group, and it is still in our practice as a pain treatment option. When we take a look at the neuromodulation, neuromodulation has higher success rate, and it is reversible. That means so we put the electrode or either put the small catheter through the relevant area that we want to alter the neural function. These can be removable. Then most incision and implantation related scarring and procedure are relatively small. So, and as well as a relatively minimal invasive procedure, neuromodulation procedure. However, it is very expensive, necessarily high technology and high level care, and multidisciplinary approach, because before going through the any neuromodulation, so we have to make sure neuropsych manner and behavior manner patient is doing well. We need neuropsych assessment. We need to make sure patient is complying to follow up, and as well as able to use the device and learn how to use this therapies. And also, patient need maintenance for this device. For the pain pump, in most, if dosage going through the spinal sac is in average, most patients 6 months need a pump refill. If high, sometimes 3 months. If low dose running every year or 9 months, may necessarily refilling the pump, either same medication or a variety of mixture to help the pain relief. And of course, neuromodulatory procedures require implantation and permanent device and maintenance. For the spinal cord stimulator, needs to be periodically rechargeable. Right now, spinal cord stimulators get smaller with the high technology, as well as improvement in battery technology. Rechargeable batteries in most that we place last long, about 13 years. For that matter, we have quite technical progress in neuromodulatory part of the pain treatment. However, still patient need maintenance and periodic every year or couple times visit to doctor, make sure programs, spinal cord program, spinal cord stimulator working, if necessarily change the programming or dosage or loading pump with medication when it get empty. So basically, current literature and accumulated data suggests neuromodulatory and or ablative procedures are safe, efficacious in treatment of intractable cancer pain with combination of optimal medical management. These procedures are not curative, but help patient a lot. And neuromodulation is providing better elongated pain relief, and it is just as important carefully select correct patient and correct procedure for intractable pain. Thank you. So I would like to have any question if audiences has any.
Yes, Dr. Kolpan, thank you very much. It was a great talk, actually generated a lots of interest. What I'm thinking, because just, because of the time, I did record all the questions that came in, and what I will do, I will pass along those questions to you, and then we're gonna just, disseminate the answers, to the people who asked them personally. Just for the matter of time. But as I said, it was a great talk and it generated a lot of interest. So I will be emailing you those questions.
I'm more than happy to do that.
Yeah,
yes, sure.
We're gonna. I promise that to everybody who asked the question that we're gonna get back to them with your answer. Thank you very much for today's talk. Thank you very much and have a good day.